Thank you for joining us for today's AANP Teaching Rounds presentation. We'd like to begin with a few notes. By default, participants' video is turned off and all participants are muted. We ask that you keep your video off and remain muted for the duration of the presentation. We will turn participants' video off to minimize distractions. We will have Q&A at the end. If you have any technical difficulties, please message the Zoom meeting host. We would like to inform you that this session will be recorded. Today's live session is accredited for CME credit. All accredited CE information may be found in PathLMS. I will now turn it over to Dr. Martinez-Laje to provide a brief introduction of today's speaker.
Thank you. Welcome, everyone. I hope those of you that were in Minneapolis had safe travels home. It is a pleasure to introduce Dr. Stephen Arnold, who is Professor of Neurology at Harvard Medical School and the Gerald Corrigan PhD Endowed Chair in Alzheimer Therapeutics at Mass General Hospital. He trained in both neurology and psychiatry, and then he joined the faculty at the University of Pennsylvania, where he was professor of psychiatry and neurology and director of the Penn Memory Center, associate director and clinical core leader of the Alzheimer's Disease Core Center, and also associate director of the University of Pennsylvania's Institute on Aging. In 2015, Dr. Arnold moved to Massachusetts General Hospital and Harvard Medical School in Boston to lead the Alzheimer's Clinical and Translational Research Unit, conducting early phase clinical trial and biomarker research. He's also managing director of the Interdisciplinary Brain Center, a collaboration of the Departments of Neurology, Psychiatry, and the Martinez Center for Neuroimaging. He has conducted long-standing research on neurodegenerative disease, pathology, molecular biomarkers, and therapeutics for cognitive decline and psychiatric syndromes in later life, and has led broad clinical translational research programs. He has authored over 400 scientific articles, reviews, and chapters. He's currently focusing on novel clinical trial designs for personalized medicine in neurodegenerative dimensions, biofluid biomarkers, which we will hear about today, immune and metabolic factors that drive dementia, and protective factors that account for cognitive resilience, all with the goal of accelerating therapeutics discovery and development. So thank you so much for joining us, Steve.
Okay, thanks so much, and it's a pleasure to be here. I think my slides are projecting well, and I hope everyone can hear me well, but let me know if not. So let's see. Hold it. Here are my disclosures, and the objectives here are, basically I'd like to sort of describe a little bit about the history of the development and validation of blood-based biomarkers, because these are now entering into clinical practice. And, in the course of this, I'll be discussing how they can be useful in diagnosis, in prognosis, in staging, and then in tracking disease progression or even treatment response. And then in the course of this, we'll also kind of learn some things about any kind of mechanistic insights that they may provide. I am going to focus mostly on Alzheimer's disease and amyloid and tau biomarkers and some associated biomarkers for Alzheimer's disease and Alzheimer's disease related disorders. If there's time at the end, I will touch on some of the developments for recognizing synuclein pathology and TDP-43, but that won't be a major aspect of what I'm saying. So just to provide the context, and I'm sure most of you have seen slides like this a zillion times before, but we are dealing with a very big disease. Alzheimer's disease and Alzheimer's related dementias, affect about 7 million people in the United States now. This is steadily increasing. It costs for mostly long-term care as well as health costs about $350 billion a year. This is expected to increase by 2050 to about $1 trillion per year. So this is a very, very big disease. It is the 5th leading cause of death. And just for comparison, so I said 7 million people are affected or living with Alzheimer's disease. 1 million have Parkinson's disease. 1 million have multiple sclerosis. About same amount, 7 million people are either dying or living with chronic disability due to stroke. And compared to ALS, ALS is about 3,500 people per year. So big disease. And forever, the definitive diagnosis of Alzheimer's disease has been autopsy. So I'm not going to belabor this slide because this is what you all do, is looking at these different neurodegenerative proteinopathies and their lesions, as well as vascular disease. So the criteria from a practical standpoint and a pragmatic standpoint, the criteria for Alzheimer's disease diagnosis clinically has been shifting. For years, there was this category of possible Alzheimer's disease, probable Alzheimer's disease, and then definite Alzheimer's disease, but only if someone had autopsy verification. With the progression in biomarkers, and I'm using the term biomarkers to include things like imaging and amyloid imaging, or PET imaging in particular, molecular neuroimaging, spinal fluid, that we are now entering a phase where the definition of the disease, which used to be based largely on clinical probability, based on a clinical syndrome, has now shifted to the use of biology to define the disease. So I tend to think now about Alzheimer's syndromes, and then I think about Alzheimer's disease, and disease is pathology. And so, as you can see now in the revised criteria, which has had some controversy to it, we now understand Alzheimer's disease as defined by its unique neuropathological findings, whether those be documented by post-mortem examination and histopathology, or biomarkers that now are, and we can talk about this a little bit, presumed to have almost equivalent value to the to autopsy findings for practical purposes and for establishing and working with the diagnosis. And we also clearly recognize that Alzheimer's disease exists along a pathological continuum, and it exists along a clinical profile, clinical syndrome continuum. And while those two things of, mild cognitive impairment, mild dementia, progressive memory loss, progressive functional decline, while those things are highly correlated, they are imperfectly correlated. And we recognize now that people can have high levels of AD pathology in their brain and yet show relatively little symptoms. So the clinical syndromes fall along this continuum here, where we have what would be called preclinical AD or asymptomatic AD or resilient AD. Those are some of the terms used. To mild cognitive impairment, when someone has some, noticeable and measurable decline in their memory of thinking abilities, but they're still basically going about their life. Maybe it takes them a little bit longer to get things done, but they can still make it independently. Whereas when people cross over, if you will, not that there's any distinctive border there, but when people advance to dementia, then they start to need help with their day-to-day independent activities. So again, I don't need to belabor this, but we've recognized this association to an amnestic type dementia for well over 100 years now with Alois Alzheimer and Auguste D. And, you know, looking at this woman who actually had a genetic form of Alzheimer's disease, a presenilin mutation, and in her early 50s developed progressive cognitive and psychiatric symptoms, progressive aphasia, and then at the time of death, using some of the new silver stains that the Germans were developing at that time, that we still use today, identified the plaques and the tangles that define the disease, Alzheimer's disease. So fast forward or slow forward 100 years, this is a kind of simplistic, mechanistic schema for this. And again, I feel like I'm preaching to a choir here. You know, amyloid beta and paired helical filament tau, neurofibrillary pathologies are the distinctive features of Alzheimer's disease. We understand amyloid plaques simplistically as amyloid precursor protein getting cleaved by beta secretase and gamma secretase, floating out into the interstitial space, and oligomerizing. These oligomers in themselves can cause some synaptic toxicity, but they're being very sticky. They tend to aggregate, incorporate various neurites in this, including tau, neuritic pathology, and elicit an inflammatory response with microglia and astrocytes. Neurofibrillary tangles, of course, you know, tau protein, an essential cytoskeletal protein, is thought to have hyperphosphorylation and other post-translational modifications that then kind of misfold into paired helical filaments, which accumulate in the cells, disrupting the intracellular machinery and ultimately leading to neuron death. Some of this tau gets propagated and can form a template against which native non-folded, misfolded tau species can start to misfold, and the process progresses in an almost prion-like way. So given this understanding of the inflammatory response, the tau pathology, the amyloid, much of the interest in developing fluid biomarkers for these is to see how much can we measure these proteins that are expressed here. And so the key blood-based biomarkers that we are working with now are amyloid beta, A beta 42 and 40, phospho-tau, various phosphorylated forms, 181, 217, 231, and a few others. There's a new brain-derived tau antibody that is now available and is showing some improvement in what we're seeing with the biomarkers. For astrocytosis, we are using glial fibrillary acidic protein, and as a general marker of neurodegeneration, neurofilament. I'll touch on these as we go forward. So the history of this is that, you know, autopsy is the gold standard for defining Alzheimer's disease pathology, and it has been a couple of decades of development in order to get us now to the blood-based biomarkers that we have. So for amyloid, you know, the first step was to identify a PET ligand that would bind with specificity to the amyloid beta plaques, and Pittsburgh compound B was the first one to really be established. This was actually some work that my colleague Chris Clark did with AVID way back in the 2000s, you know, where very nice and very difficult approach of recruiting about 50 to 100, actually over 100 people in long-term care facilities or hospice who agreed to have amyloid PET imaging and agreed to autopsy when they died. And in this, we can see several examples of one participant without dementia and without amyloid, and what their amyloid burden looked like histologically. Someone with medium burden and with a high burden. And the remarkable thing about this is that for people who showed amyloid positivity, there was 100% concordance with the autopsy diagnosis. So this basically established florbetapir, or AV45 as it was called at the time, as an excellent biomarker of AD pathology in the brain. There wasn't quite as good sensitivity. So some people did have amyloid pathology on histology, but were considered to be amyloid negative. So that may be important as we kind of follow this along for both amyloid and tau biomarkers. In any case, the next step, once you have something that has this degree of concordance with autopsy as a in vivo biomarker, you start to compare other biomarkers to it. So in these studies, comparing spinal fluid levels of soluble amyloid beta 42 in particular, as well as total tau and phosphotau, generally phosphotau 181, that these showed very, very high association, and basically about 96% accuracy at identifying amyloid PET positivity. So you see what's happening here is that we've got PET that has a certain accuracy to pathology, which is the gold standard, and now we have CSF that's using PET as the gold standard, and then we're going to start to use CSF and PET as the reference standard against which we're going to be measuring the value of the blood-based biomarkers. So I think that, the one caution about this that I sort of wonder about, even though it's just, it's incontrovertible how remarkably successful these blood-based biomarkers are now. But still, there seems to be a little bit of wiggle room that I wonder about. When you're kind of using shifting, or successive reference standards that each one are really good, but maybe imperfect at the gold, to represent the gold standard. So the same process has been happening with tau. So we now have tau, imaging that is very successful and actually FDA approved, though not typically reimbursed by insurance. At this point, it does tend to track with Braak staging, particularly in more advanced Braak stages. It's got a little bit less sensitivity in early stages, of course, and there's, starting with the pathology and looking at the concordance between the PET imaging and the autopsy, moving on to CSF and showing wonderful correlations between PET and CSF. We feel like we've got a number of tools, whether it be autopsy, molecular neuroimaging, or CSF, that can robustly reflect whether there's AD pathology in the brain. Now we move on to blood-based biomarkers, and this has been a real challenge in analytical chemistry because, if you think about it, these sort of soluble amyloid beta molecules, tau molecules are kind of seeping out from the brain tissue, into the interstitial fluid, into the spinal fluid. There's about 150 milliliters of spinal fluid in the body. As that fluid sort of leaks into the blood, you've got, these solutes that are being diluted in 4 or 5 liters of blood. And so the ability to detect such super low concentrations with any kind of reliability, sensitivity, and especially precision is a real challenge. So this has been the real challenge, and it has been very satisfying to see how successful it's been. For some things more than others. So let me move on now and talk about the blood-based biomarkers and how well they actually track onto these reference standards that we have. Autopsy, PET, and CSF. So these are a couple of studies. Let me just try to move something on my screen. Whoops, sorry. Looks like I can't. Oh wait, maybe I can. All right. So, these are a couple of studies that, if amyloid is the sine qua non of a diagnosis of Alzheimer's disease, how good are we at detecting or measuring amyloid beta in blood and having it reflect what's present in the brain as evidenced by imaging or autopsy. Turns out for most of the immune, the immuno like ELISA, and most of the antibodies were not that good. We have AUC curves, with accuracy typically in the 70 percentile range. So that's okay. If you look at the overlap, there's a tremendous amount of overlap. And so it's a little bit helpful in, predicting whether someone is more likely than not to have Alzheimer's disease pathology, but not great, and certainly not sufficient for clinical usage. Whoops. Our own experience in our lab, using a variety of platforms to measure a variety of ELISA type platforms and single molecule array Simoa platforms has been kind of disappointing, I'll say. We do see correlations between spinal fluid, amyloid beta 42/40 ratios, and plasma, but it's pretty shallow. And there's a lot of overlap between people who are CSF positive versus negative for Alzheimer's disease, and we're getting, if we just use the amyloid beta 42/40 ratio, we're getting accuracy of about 66%. That's not satisfying. Much more successful has been the strategy using mass spec with its, of course, very exquisite specificity for looking at amyloid beta 42 and 40. But it does require immunoprecipitation, and that's the major limiting factor of this technology. But as you can see in this study from Japan and Australia cohorts, we're getting very, very high accuracy, and this is the some of the data from WashU in St. Louis, and the spin-off company C2N that has been developing in this technique. And there you are getting accuracies for the A beta 42/40 ratio in the 80s, but when you combine that with age and someone's ApoE E4 status, you're up into the 90s. So yeah, so the plasma alone down here, A beta 42/40 ratio, AUC is 88%. That's pretty good. 95% is kind of like a magic number for us. And so I don't, I probably with this group, I don't have to kind of discuss this too much, but, why mass spec surpasses the immunoassays, which oftentimes are, much more sensitive than mass spec, certainly in blood. But, this may have to do with antibody epitope biases, matrix interferences, the value of the IP, of kind of, really refining and enhancing the ability to kind of measure the ratio of 42/40 and predict and use that data. Let's move on to tau. So as we know, tau is an essential microtubule binding protein. It undergoes a whole variety of post-translational modifications that are evident in postmortem tissue. If we look at the, and I'm not going to talk about what these different modifications do in terms of development. I'll just mention that we do see, many of them in healthy adults, but in Alzheimer's disease, we get a hyperphosphorylation. We get many more sites that are phosphorylated, as well as a number of other acetylations and ubiquitolations and all. We don't quite understand why this happens as yet, or I don't, but we do. And so some of the antibodies that have been developed are specifically targeting some of these phosphorylated sites, especially 217, 231, and 181. And so the first one that was really kind of looked at and developed was phospho-tau 181. And one of the reasons why is because p-tau 181 worked so well in spinal fluid. And so let's just see what it does in blood. How well does it track? And it actually does, from a standpoint of use in diagnosis, it does pretty well. This is data from the Alzheimer's Disease Neuroimaging Initiative, ADNI, looking at levels of plasma p-tau in cognitively unimpaired people, people with mild cognitive impairment, and people with dementia, presumed due to Alzheimer's disease, or due to Alzheimer's disease as evidenced by PET or CSF. And we see very nice, significant differences. The accuracy for looking at this is in the 80s, 85% range across these different kinds of comparisons, whether you're in mild cognitive impairment stage or a later dementia stage, or even people that are cognitively unimpaired but have amyloid positivity as evidenced by PET, the so-called preclinical or asymptomatic AD people. However, much better is p-tau 217. And we are seeing much better discrimination between people with Alzheimer's, with AD, with amyloid, amyloid PET established Alzheimer's disease versus people without. So here are the AUC curves, and we are now up in the 90s, perhaps even approaching 95 or more percent at p-tau 217, predicting A beta positivity or tau positivity as determined by PET. There is some overlap that's frequently seen with between these biomarkers and people with other neurodegenerative diseases, at least by clinical diagnosis, and I'm going to talk more about that as we go on with some of our data. And then we actually did a big study in over 1,000 cases from our Alzheimer's Disease Center research cohort, many of whom did have major biomarkers such as autopsy, spinal fluid, or amyloid PET. And we developed these curves in those people that had the major biomarkers. But, you know, of those people, when we look at the difference between p-tau 181 and y217 seems so much better, which it is. I mean, these are the numbers that we're getting at discriminating these major biomarker established diagnoses, 82% for p-tau 181, 95% for 217. A lot of it has to do with the dynamic range. So this is the dynamic range of the p-tau 181, you know, spread across the same cases here, whereas it's much more stretched out. So your sensitivity and the specificity are both markedly improved. So, but, you know, nonetheless, there is this sort of, you know, intermediate range. So if I look down here, you know, these are actually our cutoffs. So we have our median or our best cutoff of about 6. This is using a ECL-based immunoassay from MSD. We are, you know, our sort of 50% cut point is about 6.5. If we go up to 9.5 picograms per mil, we get 95% confidence that these people have AD, and then if we go down to about 4.5 or below, that we are 95% confident that they don't. And you can see how the people with AD and not AD fall out. But there are some overlaps, okay? And there is this very important intermediate zone that we struggle with in clinical, because, you know, we are now ordering these plasma tests, the plasma p-tau 217 in the clinic. And it's not infrequent that we get these gray areas. So what do we do? So I think the, you know, the strategy that is proposed is the right one, and that is that you can, I think the way the field is moving, it's not quite there yet, but the way the field is moving is that if you're above that kind of 95% cut point, you can be pretty confident that the person, and if the clinical syndrome fits, you can, and that's really important. If the clinical syndrome fits of mild cognitive impairment or dementia, and their p-tau 217 level is in that high cutoff range, then you can feel I would say very confident that their spinal fluid or amyloid PET or autopsy will reveal Alzheimer's disease. If they are below that 95% confidence for negative, then you can feel very confident. It's those in-between people. So in the clinic now, this is what I think some of us are starting to do is that we're getting these tests. We are using them, and people that fall into this intermediate zone then go on for additional testing with either spinal fluid or amyloid. And when you do that, you do start, it's again, they're still not perfect, and some people continue to be in a gray zone, and that's pretty interesting. But still, that it kind of makes you more confident, so that when you discuss the diagnosis, and especially now discussing options for treatment with anti-amyloid immunotherapies, it's very helpful. So we talked about diagnosis. Let's talk a little bit about prognosis. So p-tau217 has emerged as the leading and now CLIA approved laboratory blood-based biomarker for Alzheimer's disease. It is helpful not just for establishing diagnosis, but also for prognosis. So this is some data in people with preclinical or asymptomatic AD who were amyloid PET positive in the biofinder or spinal fluid positive in the biofinder and then the Wisconsin registries. And it based on the quartiles for where they were in their p-tau217 plasma level was highly predictive of how soon they would convert, if you will, or develop a AD spectrum syndrome, like mild cognitive impairment, as we can see here. So that's an added bonus. There have been a couple of more community-based samples to kind of understand how to use these biomarkers better and what they mean at different stages of life. So this is p-tau217 in the Mayo Clinic study of aging. A lot of patients, most of them were elderly. But as we can see that there are low levels of p-tau217 that were measurable in younger people, and then it started to accelerate at the ages at which Alzheimer's disease starts to emerge. And when this study broke it down, they actually found that this increase was present mostly in the people that were also, the people who had PET scans were amyloid positive on their PET scans. The nice thing about this study is that they also looked at how various comorbidities and other things like kidney disease, especially obesity, other kinds of vascular, inflammatory, and the like comorbidities affected. And so it is important in this study, for instance, people with a high estimated glomerular filtration rate had higher levels of p-tau217. So this is very important from a clinician's standpoint, because of course kidney disease also is an age-related factor and very common in our patients. And so how does this influence our interpretation of a given p-tau217 level? That's work that I think is still being kind of worked out, but I do feel that it is important for for us to do. We've been doing some work with the Aging Adult Brain Connectome project. This is about 1,000 people or so that are getting very, very high resolution longitudinal imaging. And we are seeing a very similar curve for p-tau217 in this group across the lifespan. We are actually seeing a little bit more, even in people without any kind of symptoms. We don't have amyloid PET to know, but we are actually seeing that there is an age effect even early on. Does not seem to be completely flat. So this is emerging data that we're just going to be working with and keeping our eyes on. Now let's move on to, we talked about diagnosis, we talked about prognosis, let's talk about treatment response. So, we are in a new era of treatment for Alzheimer's disease. I feel that anti-amyloid immunotherapies have been a huge scientific triumph for the field, but still quite a modest clinical advance. I think that what we see in using either donanemab or lecanemab or even aducanumab for that matter, is that these anti-amyloid immunotherapies are very successful at reducing amyloid load in the brain. These are some amyloid and then also tau PET scans showing a placebo-treated person and what their amyloid PET imaging looks like over 24 weeks, 52 weeks, and 72 weeks. We're not seeing a whole lot of change over that time. You are seeing some change in the tau levels. There is a little bit more in this placebo-treated person. Whereas in this patient here, you see a dramatic reduction, even to normal levels of amyloid in the brain that a normal control would have. And perhaps we see a stabilization of tau pathology. Here it increased 7%, here it increased 2%. So if you just kind of look at what the graphs are for this, this is the change in amyloid PET in the placebo group. This is the change even within, 6 months, you see this dramatic change in amyloid levels that kind of asymptotes out at very low levels here. While we see such a dramatic change in the amyloid biomarker, this is what the clinical, picture looks. So this is a CDR sum of boxes, and you can see the placebo trajectory downhill. Even though we are clearing amyloid from the brain and stopping progression of tau, probably, we are still progressing in terms of cognitive impairment here. And that's why I say it's still significant, it's still meaningful, it's clinically meaningful, but it ain't a home run. And the nice thing, so now moving on to the blood-based biomarkers, the phase 2 trials are reporting this, and it looks very similar actually to the amyloid imaging. We actually do see a dramatic decrease in the amount of measurable p-tau 217 in blood. I'll touch on GFAP. We also see a decrease in GFAP with treatment. Curiously, sorry, I keep doing that. We're not seeing any real change in neurofilament light, which is another biomarker that is of some use in clinical diagnostics. And we're not seeing, we may be seeing a little in terms of the amyloid beta 42/40 ratio. And it's also nice to see that even after discontinuing treatment, that the levels can remain low. Let me move on. That was donanemab, this is lecanemab. We see a dose response decrease. They reported p-tau 181. I don't think they've reported p-tau 217. So the change is more modest Again, that's sort of a dynamic range measurement issue, I think, more than anything. But still, there was a dose-related response in terms of a reduction in plasma p-tau 181. And here, this is, in their study, this is the change that they saw in the p-tau 181. And then people rolled into a open label extension.
Dr. Arnold?
Yep.
I'm so sorry for the interruption. This is just a kind reminder. We're about 15 minutes out.
Okay. All right. Okay. Thank you. So, nice to see this. These people who were on the placebo didn't have any change in their p-tau 181. They entered into an open label extension and you saw a dramatic drop. So this, really is very, very nice in terms of what we can expect the utility of just a simple blood test for AD pathology to reflect. I'm just going to touch on GFAP because I find it very, very interesting, but there's still a lot more work that needs to be done on this. This is the same kind of aging course, but it's even a little bit more dramatic that we see in our human connectome project, adult aging brain connectome project across the lifespan. These are normal, all at least people when they enter the study all have what's considered to be typical health, and they're not demented or they do not have a diagnosis of mild cognitive impairment. So we do see a progressive increase across the lifespan of GFAP. We do see, and it's curious to me, and I still don't have a good answer, that, it's most elevated in Alzheimer's disease, but even in other neurodegenerative or neural injury conditions, it's elevated typically compared to normals, but, astrogliosis is pretty prominent in a lot of these. Why is Alzheimer's disease more? If under the microscope, it doesn't seem that there's much difference. A little bit more later on this. Neurofilament light is the other biomarker. This is a intermediate filament protein that's highly enriched as kind of like stuffing in axons and neuron bodies, and with any neural injury we see that it's increased. Again, there are these interesting things. GFAP was higher in AD than these other neurodegenerative conditions. NFL is, especially high in FTD, at least in our world, huge in things like CJD or ALS. And again, same kind of curve that we saw before, but you can see here that NFL across different diagnoses, frontotemporal dementia, Lewy body dementias, it doesn't have any differential not much differential diagnosis value. Certainly not like p-tau 217. This is some unpublished data that is in revision right now, in which we used autopsy cases from the Alzheimer's Center at Mass General. And we, most pathology, we classified people according to their primary neuropathologic diagnosis, but virtually everyone has some mixed pathologies. And then we do have some people in which we had purer cases without AD pathology. So if you just look at this, in AD, or virtually everyone has some degree of cerebrovascular pathology, 70 to 100%, or 90% in these other diseases. Let's just see what this looks like. So we were actually very impressed. We measured p-tau 217, GFAP, and neurofilament light. And our first thing was to see how well it correlated with the typical ratings that you all do for Alzheimer's disease, using Thal, Sered, and Brock staging. p-tau 217, and this, I'll just say that some of these bloods that we were correlating with what was seen at autopsy, were drawn 6 to 8 years before autopsy. And yet still, we saw some very nice correlations with disease pathology extent and severity in the brain. Less so with GFAP, even less so with NFL. And then, so this actually is looking at these three markers and with people with a primary neuropathologic diagnosis and when they had the sole neuropathologic diagnosis, uncomplicated by comorbid pathology. For p-tau217, let's just look here at the sole pathology. So these are people with AD and AD, and they could have something else, whether it be cerebrovascular, CAA, TDP, 43, Lewy body diseases, other tauopathies. If you have AD, you have high p-tau217 in your blood. If you don't have AD copathology, you mostly don't. Okay. GFAP, again, the pattern is similar, but you do see some GFAP rise in these other diagnostic categories that are uncomplicated by, and when I say no AD, I'm talking about, I think we used a Brock stage 3 and below I'm blanking on what we actually, you can have a couple of plaques and tangles hanging around. Everyone does, but, or I shouldn't say that, but most people do, as you know. And then NFL, the TDP-43 proteinopathies have even higher than Alzheimer's disease. It is across the board. It's not a bad marker of non-specific neurodegenerative disease. And we actually, divvied things up. I'm not going to go into this, but the message is pretty much the same, but we looked at all these different diseases and their primary diagnosis with if they had comorbid AD pathology versus not comorbid AD pathology, and how that changed. And basically the message is the same, that, p-tau is present in AD, whether you have, and it doesn't seem to matter if you have something else or not. And if you don't have AD pathology, your p-tau217 is low. And then it's a little messier for GFAP, and it's very messy for NFL. So I will skip this. I'm just going to mention that, the huge unmet need in the field is for blood-based biomarkers of synucleinopathies and TDP-43 proteinopathies. These are important contributors. They're hard to distinguish. They do have major, the presence or absence of these has major implications for treatment approaches, for clinician diagnosis of patients, for prognosis, and I'll just kind of stop by saying we've got some decent measures for synucleinopathies in spinal fluid and skin biopsy, but the plasma-based biomarkers are really just in lower development. Some of you may have more advanced knowledge about this than me. TDP-43, we're even in a little bit worse shape. Because we don't have really good biomarkers in either CSF, we have no real imaging biomarkers, and certainly not blood-based biomarkers. So to leave us some time for questions, I'll just end on this slide, which I like to have, is that these diseases, many of which we call Alzheimer's disease, but encompasses, that this is a complicated disease. There are many different pathophysiological mechanisms. We just happen to define it by the presence of Alzheimer's disease anyway, by the presence of plaques and tangles in the brain, though there's probably many different pathways. And I think, being able to kind of capture this develop biomarker profiles so that we can appreciate different contributions, I feel is going to be, it is essential if we're ever able to move towards more personalized or precision-based diagnosis and management. So I'll just acknowledge some of the people in the lab, especially Pia Kivisak, and actually Hadia did a lot of the work with the, ELISAs. I'll stop at that point. Let's open it up to questions.
Thank you so much. There have been a couple of questions in the chat, but the first one was already answered in your later slides. So we really only have one question for now. It says, since CSF is mainly reabsorbed in the venous circulation, is there any data to suggest differences in blood ratio, blood or serum marker testing, possibly lower detection in patients who have been VP shunted, like a very specific situation? So.
Oh God! All right, so you're pushing my button because I actually happen to run the neurology side of the normal pressure hydrocephalus program at Mass General. This again has been a very confusing thing. In the and I don't know. We're trying to find out that question. So one of the problems is that when you send CSF off for AD biomarkers, very often in NPH, very often everything comes back low. Okay. And I've talked to, I can't remember her name. She runs the lab at Mayo Labs, who does a lot of these. And she was saying, well, it's probably some kind of dilutional effect. I don't quite understand that in CSF. So what we've been doing lately is, whenever we do a large volume tap for diagnosis of normal pressure hydrocephalus, we send off the AD biomarkers because, again, the ratio of amyloid to tau may be informative, even though overall the levels are down. But I've also been sending some plasmas off, and I don't have the answer yet. But looking at the ratio of p-tau, either 217 or 181, between plasma and CSF will be kind of really interesting and probably get us around this problem that we've had with CSF.
Okay, and then there's a comment about, there's good evidence that ApoE4 positive AD is somewhat different disease than ApoE4 negative AD. And that it would be fascinating to dive deeper into, biomarkers, looking at them separately for these two groups.
Yeah, so far the data that I've seen, and that even some of our own data, we're not yet seeing a whole lot of difference between ApoE4 positive versus negative in these biomarkers, whether you have dementia or MCI. I've not been that impressed with it, but I have to say I haven't. It hasn't struck me. Put it that way. That doesn't mean it's not there, and I haven't looked at it, but I don't know. Yeah.
Mm-hmm. Okay, maybe one more question. Very nice talk. I wonder if you might comment on the potential of MTBR tau 243 for staging tauopathy in AD.
Yeah, so that's a very hot area right now. And so, this is, again, it's kind of like IP mass spec based work. But the initial findings do look quite promising and quite interesting. It's just, it's like the mass spec, it just doesn't scale. It's hard to, we need better technology, more robust technology in order to kind of generalize its use.
Yes, that sounds good. Someone raised a very good question, but I'm not sure that we have time to discuss about the potential misuse of the biomarkers by the general public or clinicians who don't fully understand how to use them.
Yeah, so we think about that all the time. Um, Especially when I think Quest or someone came up with a, direct to consumer measure of amyloid in the brain, in the blood, which we know has about 70% accuracy, what that means, and the misinterpretation. So, yeah, I'm all for consumer education. I'm all for kind of, but it's like interpreting like any lab test, interpreting it and what it means for a person requires context and counseling. And I worry about the direct to consumer. We have, of course, people with 23andMe, when it used to be a thing, would come in. I have Alzheimer's disease. They'd show you their E4 result. And, you'd have to spend the hour telling them what that meant and why they didn't have Alzheimer's disease. Interestingly, disclosure is an important thing. I think the field has gone through a lot with the amyloid PET scanning and the CSF to kind of for what the impact of disclosing amyloid positivity is. And by and large, the impact, people worried, suicide and things like that. By and large, at least early on, the only thing that people did different after they learned their amyloid status and they were normal is that they bought more insurance. That was about it. So.
All right. Well, thank you so much.
Okay.
All right. Well, thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credential. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Arnold for an excellent presentation. This concludes the session for today.